So speaking next is going to be Rita Wittman. Dr. Rita Wittman is a community respirologist and general internist who works at Langley Memorial Hospital. She's the medical director for the Home Oxygen Program for the Fraser Health Authority. And prior to her medical career, she worked as a registered nurse in the North. She's worked for 23 years in the Langley community. She dedicates her time away from medicine to cycling, gardening, biking, and cooking with her friends. Awesome. That's great. And today, Dr. Wittman's going to be talking about the burden of COPD. Thank you so much.
All right. So I was tasked with talking to you about the burden of COPD, and I have to admit I took some slides from other presentations that I give to doctors and other healthcare professionals, so some of the slides might use terms that if you need clarification I can help with, but I also tried to focus my talk, because I was asked to talk about the burden of COPD in particular, and I'm trying to focus it on a patient audience. So, oh, sorry about that. Let's see if I get next instead. There we are. This is a rough outline of my presentation. So I actually threw in a little slide about what is COPD. I think that's kind of interesting to sort of frame our discussions. And then when I'm talking about the impact of COPD, I wanted to talk about the impact that you feel personally, but also to highlight what caregivers might feel, what the healthcare system feels as a whole, and also talk about just an introduction to general treatment options, because I know we have a speaker who's going to talk about that in greater depth. So I have disclosures, and I talk for other companies, and thankfully AstraZeneca and GSK, who are big companies in the COPD world, I've borrowed a little bit from their presentations. This is a talk where I'm not going to promote one product or another, just it's important, and whatever I talk about is evidence-based. First of all, what is COPD? For those that live with COPD, they have symptoms daily, but what is it that is at the level of the cells inside the body or the organ? How is the lung affected? It's a condition where essentially it's much harder to get the air out of the lungs, in a nutshell. And the reason for that is that the airways become clogged with mucus, or they're narrowed, and there also are holes in the lung where air gets trapped and it can't be exchanged, all right? And that we further in the lung world define it by lung function. And it's interesting what I mean by lung function. So you can have a cough all the time. You could have chronic bronchitis, but your doctor could send you for a breathing test and you might not meet the lung criteria for COPD. And that's important for you to know that we have these little definitions. And these definitions, they've also changed a little bit recently. And that's maybe important for you to know, because how the doctors interpret lung function, we're going to use different words, but you might still have the same symptoms, and you might be at risk for COPD and have some of the symptoms that lead into it. So that's just important for you to understand. It's a subtle concept. So one of the main, probably the main trigger or instigating factor for COPD and its cause is smoking. And unfortunately, that's a picture I took off the web. And there are in some countries where the rate of smoking is quite high. In Europe, for example, and yes, in South Asian countries it's quite high. We're lucky here in BC, our smoking rate's probably under about 17% now. Yeah. What causes COPD is not just smoking, though. That's very important. We're going to have a speaker today, I think, that will talk about air quality and air pollution. And we recognize that there are a significant number of people who meet the criteria for COPD who have never picked up a cigarette or any other kind of inhaled noxious chemicals, but they maybe have worked in an environment that was very dusty. So grain elevators, for example, or have lived in a country where they were, as part of their caregiving duties, cooks and were exposed to biomass fuel pollution. We see this a lot in the Indo-Canadian community, where people have previously cooked with sort of open flame, and as a result of that been exposed to chemicals. So not all COPD is related to smoking, and that's very important to know as well. The amount of people that are affected by COPD is actually quite high. In our numbers within Canada, it's estimated that there's at least 2 million people living with COPD. And as Janet said, there's probably people living with COPD who don't know they have it either. And what they've done, if they have shortness of breath, which is a common symptom, they've constricted their activities to accommodate for their abilities, or said, oh, it's because of my age that I'm now short of breath, not recognizing that perhaps they have COPD. It is actually one of the leading causes for hospital stays and duration of hospital stay, except during the pandemic. During the pandemic, when we look at hospital data, a lot of our patients with COPD have been frightened at the thought of going to hospital and have stayed sheltered at home and have become more deconditioned but avoided hospitals. So some of the data most recently doesn't show the same number of admissions, but that's because they've been too scared to go to the hospital. In general, COPD is a slowly progressive disease, and it's not just a disease of shortness of breath. It affects the whole body in many ways, and actually one of the most common ways it affects people is that it is a contributor to the development of anxiety and depression. It's a very, very common other health problem that people experience when they have COPD. So the other thing about COPD is it's an equal opportunity disease. At one time, it was a condition that predominantly affected men, but in our society, women have become equal opportunists and also are now representing the COPD population in equal numbers. Interestingly enough, not always in research findings. A lot of the main studies that are done often will show a predominance of men, maybe 2/3 or a little more. So there's an underrepresentation sometimes in the studies of women. Back to exacerbations. So when we talk about COPD, and I'll circle back to this time and time again, the impact of COPD to an individual is not only shortness of breath, but it's these episodes of exacerbations, or what we call lung attacks. And they are, as I said, a very common cause of hospitalizations. In fact, they're the second leading cause of hospitalizations and readmission rates to hospital. And this has been an opportunity for us in the lung world to plead with our healthcare providers that for this reason, we need to sort of focus more efforts and more help toward this, because it's consuming a lot of healthcare resources. And for a long time, patients in this area have not had enough research dollars or efforts targeted toward their situation. So how does COPD affect individuals? In studies, we know that it affects your normal exertion, so that most people say that they are not able to do the things they once did. As a result of that, social activities are also affected. Ability to join with family, go outdoors and other activities, even sleeping is affected. And of course, household chores. I mean, for me, when I talk to patients about COPD and I'm trying to get a sense of how it affects their abilities, I'll often say, do you have shortness of breath? How far can you walk before you get short of breath? And I'll get an answer like, oh, not very far. I said, well, I need a measuring stick. Give me an idea. What do you do that makes you short of breath? And if I don't get any answers, I'll be like, okay, well, how about having a bath or a shower? Does that make you short of breath? What about making your bed? Turns out making the bed and vacuuming are very hard things to do. If you don't vacuum, well, how about just carrying your groceries in? Or, as I said, dressing. So those are things that are really important ways for us to gauge someone's shortness of breath. Some of our patients are also working and trying to continue working. And I remember one of my patients who had actually quite a physical job, a real physical job, and he would even walk to work. And he said to me, I'm getting into trouble. I can't do this, especially after that last lung attack I had. And it did lead to his early retirement as a result. And of course, back to the whole social connection, when people have problems with shortness of breath and they can't do the things they once did, for example, play with grandchildren or go on family outings, that also affects family activities as well. So broad and far-reaching impacts to individuals. This shortness of breath, or we call it dyspnea also in medicine, it causes people then as a result to compensate by affecting their activity, and I say they constrict their activity. And as a result, they avoid certain things, and that avoidance leads to more deconditioning. And I know when Jan was talking about the pulmonary rehab program and how the exercise program helped her to be able to cope with her disease, that was very important. A lot of times people now become short of breath, not because of the COPD, but because of the deconditioning that they get from avoiding activity. And that is something that's reversible and can be improved. One of my patients who came from Alberta had been on a transplant list in Alberta, but as one of the conditions of her being listed for transplant, she was obligated to participate in the rehab program. Her functional ability improved so much that she was taken off the list. She improved so much. So that's a testament to how sometimes cardiovascular deconditioning can also be behind the shortness of breath that people have. And then again, that spiral, if you're not as active, it leads to social isolation, and that impacts on mood and all the other things as well. As I sort of alluded to, the experience that people have with COPD is multifaceted. And you don't have to read all the bubbles there, but what it's trying to say is there's the individual experience, there's the social experience, the psychological, the symptoms you experience. There's also impacts on the rest of the body as well. And these are things we're going to explore a little bit more. So the impact, individuals, to caregivers, to society. I love this slide. This is a borrowed slide, and I actually don't even remember where I got it from, but this slide is to show you that we as doctors used to be very focused on lung function and think that that was the be-all and the end-all that we should focus our treatments on and understanding how COPD affects people. Turns out it's not the thing we should be looking at. We should be looking at your functional ability, that is how far you can walk, what you can do, and how often you have lung attacks. Those two things, that shortness of breath and how often you have lung attacks, are things that we target our treatments on, and it's a better way of gauging the severity of COPD. In this picture, all three men, who look different, have the same level of lung impairment. We use this number called the FEV1, which is how fast you empty your lung in the first second. And because the pipes in the lung are clogged up with mucus and such, it's hard to do that. So that number is reduced. But that number doesn't translate necessarily with the person's ability to do things. You can see that the younger gentleman on the far side there has an FEV1 of 33%. He was able, on his 6-minute walk test on the bottom there, he could do 410 meters. The fellow in the middle, same kind of lung function, could only do 157 meters. And the gentleman on the far right, I guess you're right, yes, did 280 meters. So that lung function doesn't explain your ability always. And that's hard for people to sometimes understand. Rather, shortness of breath is a better way. So you remember when I said to you, I try to assess, when I see people, how is it that your COPD impacts you? We often are focused on how short of breath are you. So in the medical world, we have this grading scheme called the MRC, or modified MRC scale. This is important. They use this in research studies, and we use it also in medicine to sort of measure how short of breath you are. And we use this as a way to decide the treatments that might benefit you, and that's very important. To sort of show that, this is there's two slides, or two sets of slides here. And what they're trying to do is trying to say, what's a better way of assessing someone's risk for basically dying? So if you look at the graph that's closest to me, it's your likelihood of being alive based on lung function. And there's different levels of lung function, and you can see the lines are clustered together. Lung function is not as great a predictor of who's going to be alive today, tomorrow, or next year. On the other hand, if you use the shortness of breath measuring stick, as defined by these different grades, and they changed the grading scheme, so this one was up to 5, whereas now the modified scale is up to 4, but the end result is the person who has the grade 5 shortness of breath is the person who's short of breath dressing with activities of daily living. So that individual, most of them are gone, no longer in this world after 2 years. And that is a better predictor of survival and helps us to identify those that are at risk. So I've said that shortness of breath and measuring it's important to know how COPD is impacting people and assessing their prognosis. The other big thing is exacerbations or lung attacks. So an exacerbation basically is a worsening of three things that we kind of define in particular. But usually it's a combination of shortness of breath that's worse than usual, more mucus than usual, and mucus that's more mucky than usual. You can have very mild things where there's maybe just a bit of shortness of breath, the air pollution's a bit worse, you take an extra Ventolin and you're better. But if it's anything more than that, where you have to take something additional medication such as an antibiotic and or prednisone, we consider that moderate if that's the case or severe if you're ending up in hospital. These exacerbations are very important. They're like the heart attack that a heart patient has, and our COPD patients, this is the lung attack. And we use those words for good reason, because exacerbations, the ones that lead to medication changes, and especially the ones that lead to people being in hospital, are very severe and have consequences, which we're going to explore. What causes an exacerbation? Basically, it's triggered often by air pollution. It can start off as a virus and then have a bacteria, or can be a bacteria to begin with. Those are the common causes of exacerbations. And then as a result, the airways become inflamed, there's more mucus, the muscles around the pipes clamp down, and the end result is that it's harder for air to get in and out. But there also is this, we call it inflammatory cascade. So there's these chemicals that are released, and they too harm the body in different ways and can increase the risk of heart consequences or cardiovascular consequences. If you have exacerbations, unfortunately, that leads to a decline, a more rapid decline often in lung function and functional status. And this graph just shows a study of a small group of patients, by the way, and what happened to these patients in terms of their survival over time. And it basically shows that having exacerbations, the more you have them, the more likely that you won't be in this world. They're dangerous, but they also rob you of lung function. Now, this I learned recently. I didn't really appreciate this, and I think this is really important for anyone that's affected by COPD and their caregivers to be in tune to. And that's that many patients with COPD don't always recognize or report that they're having a flare-up. Because what they do is they kind of just, this is the normal. I think this is just me being more short of breath, but not recognizing sometimes that there is symptoms that are defining a flare-up. And so up to, in different studies, it's across the world, it ranges from 40 to 70% of patients didn't recognize that they were having a flare-up. And this was uncovered because when researchers did studies, they gave patients different diaries to track their symptoms every day. And there's different ways you can do that, but they had these diaries, and then afterwards the researchers went in there and it's like, wait a minute, this person was having a flare-up, and they never told us. Why do people underreport? I kind of sort of said that, maybe it's because they constrict their activities. Some people are ashamed. There's a lot of self-shaming that occurs when people are experiencing symptoms. And I think it's because one of the triggers is related to smoking, and people may think that I did this to myself, I'm not going to tell someone about it, it's just whatever's happening is happening to me because I did it to myself, and people don't want to bring it up, right? So there's many reasons, but I think a lot of times it's just not even recognizing it. We don't have like a little measuring stick every day that we can go, that something's alerting and beeping at us that something's wrong. And if you're short of breath every day, maybe that day is worse than the next day. You're thinking, well, maybe it's just getting worse every day, versus it really is worse and it's a flare-up, right? So it's not easy. The consequences of flare-ups, even before someone recognizes they have a flare-up, if we were measuring your lung function, we could see things going down. So this curve is trying to show, at the bottom of the curve is when someone is recognized to have a flare-up. And the line before that, in the weeks prior, has shown a bit of a decline already. And often when people, quote, quote, recover from a flare-up, they don't necessarily recover completely. And that's really important. And I like to use the forest fire analogy when I talk to asthma patients, but I also like to use that analogy with COPD patients. If you can recognize your exacerbation and act upon it sooner, you will be able to treat the condition and have less negative consequences and better chances of recovering from the injury to your lung as well. This is very interesting, and I kind of alluded to this before, that patients with COPD, they don't just have one condition. Half of the patients with COPD often have underlying cardiovascular disease. When we look at why patients die who have had COPD, not everybody dies from respiratory failure. Actually, a significant number of people die from heart attacks. Some die from lung cancer. Those are the big three. But also underpinning that is that people often have other common health problems, such as anxiety and depression, osteoporosis, all these other things. It's very important. And why is that? Well, no surprise. It's because oftentimes the risk factors for COPD are shared with those other conditions. And so this is really important. So the impact of an exacerbation. So we know that if you have COPD, you're more likely to also have underlying heart problems. If you have a flare-up of your COPD, remember I said that what happens, there's an effect on the airways. There's also an effect on the chemicals that are released in the body that increase the likelihood of what we call plaque disruption in the heart or in other blood vessels, so that people are at greater risk with a COPD flare-up of a heart attack or stroke. And it's especially so in the first 10 days, but even more so, if you will, in the year subsequent. So it's very important to make sure that you have a thorough assessment, to look for these other factors, but also, again, treat flare-ups quickly, recognize them, because untreated, these consequences are worse. Basically, the more often you have flare-ups, the more likely you are to pass away. Not all flare-ups are created equal. The most dangerous flare-ups are the ones that put someone into an intensive care unit. Those are very high risk. And again, very important to have that treated. And I would say if someone has a COPD flare-up that is bad enough to be in an intensive care unit, or potentially even hospitalized, they should probably be seen by a lung specialist at least once. I'm going to skip ahead a little bit. I've alluded to this already, that the things that cause cardiovascular disease to be more common and also cause COPD to be more common and lung cancer are shared risk factors like smoking. So that's why we see these things clustered together. Now, coming to a close, I want to just sort of give a hint of what's to come in other presentations. Treatment of COPD, there are good options. Many patients, though, unfortunately, when they leave hospital after flare-up, are not even getting some of the maintenance medication. In fact, in different studies, up to a third of patients sometimes don't have what we would consider standard maintenance medications. And our treatment guide has been what we call a stepwise approach in COPD. And this might be changing because we have newer therapies that we're recognizing can really reduce flare-ups, which are dangerous. And so I want to introduce this stepwise approach. This diagram, you don't have to worry about recognizing all the letters on it, but this is a guide to doctors on how to treat people with COPD. And on the side closer to me, people with milder disease, and they talk about CAT score. That's a way of measuring your symptoms of cough and mucus and shortness of breath, etc. Or your MRC score, your shortness of breath score. If they're milder, we don't necessarily advocate as strong a maintenance medication. You might use what we call short-acting bronchodilators, that's SABD. But if there's more symptoms, we add in the LAMAs. We call those long-acting antimuscarinic antagonists. So those are the medications we add. But when people get more symptoms, so they have moderate to severe symptoms or getting flare-ups, we add in more medication. And I'm not going to steal the thunder of the next speaker, but that is very important that we layer in more treatment. But we're beginning to wonder maybe we shouldn't be holding back on some of these good treatments, especially if they prevent flare-ups. We know that if you don't treat flare-ups, I kind of hinted at that forest fire analogy, that if you delay it, it increases the risk of having more exacerbations, increases the risk of mortality. It increases the risk of more exacerbations. If you want to know who's going to have a flare-up, the risk factors are you had one already. a lot of mucus production, that kind of thing. Those are important risk factors. And we want to prevent that because we know that those are dangerous. Yep. So I'm going to wrap up. This is my closing slides. Just to say that while we have medications for COPD, we also, and this is important, have treatments that are non-pharmacologic, such as smoking cessation, pulmonary rehab, a shout out to that, very, very important. And I think also the social supports that you get from patient support groups. And I'm going to just wrap up. So the health impact of chronic COPD is substantial and increasing. Despite this, we know that COPD receives less attention and less funding than other long-term conditions. Having said that, we do have treatments that can help people with the consequences, both physical, social, psychological, and cultural, and economic to the system that could reduce the burden of disease. My final slide, I always love Far Side. The real reason that dinosaurs became extinct. Yeah. So I think I don't have a lot of time for questions. We'll probably, oh sure, I'll take questions if there's some.
Thank you so much, Dr. Wittman. So I think you're just able to stay for a few minutes.
I will try to stay till noon, but I have to get back to my office.
So we'll take a few minutes for questions. I've got some questions, but I want to start with people here, and there might be some questions online as well.
Sure.
I'm going to use the mic because there's people online.
Thank you. That was excellent. The question I have is, this would be 2 years ago, I thought I was having a flare-up. And so I went to the doctor, I got medication, everything was on prednisone, did what I was supposed to do. And this one night, about 11:30, I could not breathe. I tried in the tub, having vapor, the whole meal deal. Anyway, I ended up calling an ambulance to come and get me. And it turned out that I had a pulmonary embolism. It had absolutely nothing to do with the flare-up. So that kind of, if anybody else is out there, if you can't breathe, just call an ambulance, And anyway, what would be the difference in the symptoms?
So, one of the clues might be that there wasn't cough and mucus, possibly.
But I never had that anyway.
So then maybe did you have any chest pain, especially sharp pain when you took a deep breath? Did you have any swelling of your legs?
In my what?
Swelling of your legs.
Oh, I would have no idea. I wouldn't
Okay.
even have probably
So
paid
basically,
attention.
in a nutshell, you did the right thing. You went to the hospital. Sometimes there's clues that would suggest a blood clot. One of the risk factors for a blood clot is having been in hospital recently. And people don't always get blood clot preventing medication because if you're in hospital, you're a little less mobile. So that's a big risk factor for a blood clot. So that would be probably what was your risk factor. But ultimately, when your shortness of breath wasn't getting better with things that normally worked, you had to seek medical attention. Shortness of breath has many causes. There's a collapsed lung, like a pneumothorax, heart attack. Some people don't have chest pain, they have shortness of breath. You can have rapid heartbeat, you don't always feel it. Heart failure, or in your case, a blood clot. That's why going to the hospital is important. The emergency room physician and staff will do a series of tests from x-ray to blood work. They'll do a D-dimer, which is the blood test for blood clots, and then that will in turn trigger them to do the special CT scan of the lung that diagnoses the blood clot. So thankfully you got treatment.
For sure.
And you're
For
here
sure.
today. Yeah.
Yeah, thank you.
Thank you, Jan. Yes. And I will remind everyone to, if there's some yellow paper on your table, so in case we run out of time for questions, please write your questions down, and you can give it to us, and we'll ask them later or save them for after the session. And there is going to be a longer Q&A session right before lunch as well, but I'm not sure if Dr. Wittman will be here when we get to that.
Yes, I just wanted to say, I don't realize if I'm having a flare-up or not, because I also have asthma. So I could be out and someone's wearing perfume or whatever, and I'll start coughing like really bad and have an asthma attack. But then, sometimes when I'm at home, just sitting, watching TV, but I'm sitting in a bad position or whatever, I've just had something to drink or whatever, and then all of a sudden I'll have a big attack. Now, I don't know if that's an asthma attack because of the way I'm sitting, or if that's a flare-up. So it's hard for me to tell.
Yeah, sometimes it's even hard for the doctor when they're talking to know, but the key features for a flare-up, like a COPD flare-up, there's three main defining factors, and that's increased shortness of breath from your usual level, and it's persistent, not just for that day, it's more than a day, potentially 2 days, and increase in something in the mucus, either the volume of the mucus or the discoloration, more yellow or green, and that's usually how we define it. And then I have some people who say, you know what, you know you keep harping on this mucus thing, but I never bring up mucus. So we have to individualize our definition of a flare-up for some people. And like I said, sometimes it's even hard for the doctor to sort it out. And so what I would do is share that experience with your doctor and see if you can tease out what it was and what are the clues to your situation. It's not always straightforward because we don't have a blood test or something that says high or low. It's kind of these symptoms that are hard to sort out, but it's a change from baseline that's persistent in those three main things I mentioned to you that defines a classic COPD flare-up.
So much, and I think we need to move on to our next.
Thank you, everybody.
Thank you so much, Dr. Wittman.